looked at me and he said something that would influence my career decades later. He said, "Son, I don't know how you'll take this, but a lot of this chronic pain is psychosomatic." And I was like, it's like getting hit with a blast of Arctic air on a warm day. You just don't expect to hear that when I'm talking about knee pain.
Hey there, and welcome to the Heal with Grace podcast. I'm your host, Grace Schechter, and I'm a holistic licensed therapist and nervous system coach who believes that the chronic and often unseen symptoms you're living with are a sign of something deeper going on, a sign that your nervous system needs attention. In each episode, I'll share the science behind the most common chronic health disorders, plus holistic tips using mental, physical, and spiritual practices. You'll hear what I've learned in my journey and the true stories from our trusted guests, so you can feel less alone in your experience and give yourself grace no matter what you're going through. So without further ado, settle in and get cozy. It's time to heal with Grace. Hi, Dr. Schechter. Thank you so much for coming on the Heal with Grace podcast. I'm excited for this episode.
Thanks for having me.
Yeah. So why don't we just go ahead and jump right in? And how about you tell everyone listening who you are, what you do? I'm sure, honestly, people listening to this know who you are, but let's give them a good introduction of how you came to be here.
Yeah, my name is David Schechter, and I've been in this field for a very long time, having met John Sarno as a medical student and continued to do some research with him. I'll tell you more about that when you ask, and moved out to California for my residency and eventually started a practice here, and he started referring some patients to me very early on as this movement became a little more known nationally. And then over the decades, I've written Mind Body Workbook and other books, Think Away Your Pain, treated thousands of patients, developed a community of therapists in the Southern California area who I've been able to refer to, and now it's grown even beyond my capacity to refer to them. They've done a lot of great work on their own. And I've been involved with the national nonprofit as well, which is now called the ATNS.
That's right. Okay. Amazing. I do want to understand your work with Dr. John Sarno and a couple of reasons. One, obviously, that's interesting. For those who are listening, you founded, in a way, right, back in, the 70s?
Yeah, 50 years ago, I would say, yeah.
Yeah, really understanding more of the mind-body component to chronic pain. And his book is actually the first book I read about 12 years ago in my first journey with chronic pain. I saw a psychologist who had done some work with him, who then was helping me. And so that was my first intro. And I just find it fascinating. That was also yours. So why don't you give us a little bit of idea of what happened back then?
Yeah, Dr. Sarno, now known as a kind of a legendary figure in the field, passed away about 10 years ago. But in the 80s, when I was a young medical student at NYU, I was having knee pain that wasn't going away. And I went through the usual, student health and orthopedic. And then I walked into Dr. Sarno's office. He was not known yet as a mind-body physician or guru or whatever you'd call him. He was just a physical medicine rehab doctor who had lectured to us in anatomy. So I walked in and said, is there some physical therapy you could recommend? Here's what's going on. And he asked me a few questions. And then he looked at me and he said something to me that would actually influence my career here decades later. He said, "Son, I don't know how you'll take this, but a lot of this chronic pain is psychosomatic." And I was like, it's like getting hit with a blast of Arctic air on a warm day. You just don't expect to hear that when I'm talking about knee pain here now. And he said, "I see you're skeptical. I don't have much time, but you can come to my seminar next Monday night. And if it interests you, I'll examine you as a patient and we'll talk more about it." So he was giving seminars to patients. And I figured, what do I have to lose? So I took the information down. I went to the seminar the next Monday evening. There were a lot of well-dressed Upper East Side, Upper West Side New Yorkers, and me in the first row with, corduroy pants and a plaid shirt, the medical students sitting there attentively. And what he presented in his presentation, remember, he was using slides in those days. There were no PowerPoints. So, the technology is historical now. What he presented in his format of explaining pain made sense to me. I was stressed out about medical school. I was a worrier, maybe putting too much stuff on myself, trying to figure out an answer, catastrophizing, all the stuff that we hear about now and that we work with patients on. And I talked to him briefly after the session and arranged to see him in the office. But when I went home that evening and sat down on my bed in my little room that I was renting from someone and staring out at a brick wall, which was the actual view I had out the window, not a very exciting view, but I felt like a weight was lifting off of me. So just that evening gave me hope, gave me a sense that maybe there was a solution to this that nobody else had found, and that a solution that made sense. So I subsequently went to see him to be examined like a patient. And he confirmed that I had what he then called TMS. We're calling it other things now, neuroplastic symptoms, but he called it TMS at that time. And he said, you should come to my other seminars. And there was no book then. There were no videos. There was no internet. I hadn't written his first book. I eventually helped him with his very first book, Mind Over Back Pain, which is not as well known. And so I went to the seminars. I thought about what he was teaching, and my pain started to lift over the next few weeks. I got back into jogging and basketball, and those were the things that I really enjoyed doing. When I discussed this with the medical students and doctors at NYU, my amazing recovery over a short period of time from pain, they really couldn't integrate it with the information they had. They kind of scoffed at it or thought, well, that's good for you, Dave, but that probably doesn't help most of the patients. So I didn't get much support there, but Dr. Sarno and I were able to get a grant for me to spend a summer with him during my medical school career. So I spent an entire summer in his office and calling up other patients that he had treated for a little research study, and 175 patients. And I kept hearing the same stories over and over again, like I had, which was I went to a few seminars and I was examined by him and I changed the way I was thinking. I changed my attitude and the pain went away. And so I kept hearing this over and over again. And so you can't say it's just you. It's actually happening to a lot of people. You're hearing their stories. And I was examining patients with him and learning about his approach. So it was a great summer and it inspired me. But, then you go back to medical school and you sort of learn that more reductionist, non-mind body model that is modern medicine. And so it took a while for me to be able to get through residency and start to really apply this in my own practice. And by that point, we stayed in touch intermittently during that time. I had moved to California, but he had written his second book, ultimately to be a bestseller, called Healing Back Pain. And he said, I'm getting a lot of calls from all over the country. I don't have anybody to refer them to other than himself, but he only liked to see people in New York. So he started referring a bunch of people from California and Arizona and Nevada and Colorado, because there was nobody, to me. And so that gave me an opportunity to develop seminars like he had, and eventually to write the Mind Body Workbook a few years later. And it's just develop a really detailed program on how to help people, because I had so many people calling up to come in from all over. And so that was the beginning of my journey, first as a patient in recovery, and then as a physician incorporating this model into my work.
So when you started as a physician, you started doing this work right off the bat.
Pretty much. I mean, you have to go to medical school, you have to do residency. Right. And then initially I'm doing some urgent care, and, you talk to people. I could see how you talk to people made a big difference. I was in this one clinic where this gentleman next to me, this doctor next to me, would see people and he'd say, he looked at an x-ray, go, you have these degenerative changes on your x-ray and this kind of thing. It's a horrible word in medicine, horrible. And then I would look at them and I'd say, your x-ray looks good. It's just, normal for a guy 45 who's been lifting suitcases at the airport for 10, 15 years. I said, you'll be fine. Just take a week or two, you'll be fine. And I noticed that my patients got better, and this other guy's patients was in treatment forever for physical therapy and other things, because they thought there was something wrong with them, right? And I was explaining to them, you lifted a suitcase too heavily. These were guys who worked on the conveyor belt system at LAX, industrial workers. And so I noticed that how you communicated to patients made a difference. I didn't yet have a formal program to help them that way. I started teaching at a residency program. And again, I found that if you listen to patients and you listen to their story and you spoke to them in the right way, that it made a big difference. I mean, language is how we access the brain in a sense. Language is the software of the brain, I believe. And so the language I was using was different than the language most physicians were using, because I knew about TMS. But it wasn't until I had my own practice and then I could start seeing people and spending more time with them than you do in urgent care or teaching at a residency program, that I was really able to develop the kind of program for pain that I've continued till now. That was more like Dr. Sarno's program, even if it's not exactly what he was doing. Because over the years, Los Angeles is a tough place to get people together in person. Now we have Zoom, but we didn't have that decades ago. So I would say, okay, come at 6:00 on Monday and I'll do a seminar. But, 3 people would show up and the others would call me and say, the traffic's terrible, I can't make it, whatever. So the solution to that was to develop a home program. And so I started to record the seminar that I was doing. I started to write this workbook. I started to create other materials so that after I diagnosed them, they could do this home program and then come back and see me after doing the homework. And Dr. Sarno had incorporated some elements of homework, but he was relying on, more of the live seminar and teaching and that type of thing, which was more conventional for that era and a little bit easier in Manhattan than it was in Los Angeles. You could take the subway to his seminar in New York and LA, you're just in traffic and endlessly at that time of day. But, the field has evolved. My approach has evolved somewhat over the years, but it comes down to diagnosis and education, and psychology. That's what it really comes down to.
So you see people, you assess them and diagnose. Do you also treat physically, or is it pretty much mostly mind body?
So in my I have a practice. I'm board certified in family medicine and sports medicine, and my niche in chronic pain, TMS, mind body. So there are people who I see with a sprained ankle. They don't need to necessarily hear about their stress. They just need to be treated for that. There's people who come in with, they're in a car accident. It's been a week or two later, and I'm just, giving them reassurance, and I maybe give them some muscle relaxants or have them see physical therapy for a couple of weeks. This work tends to have the most power in chronic pain. People have had pain for 3 to 6 months or more, and the neuroscience backs that up in terms of the functional MRI imaging and that kind of stuff, which is that acute pain is different than chronic pain. It's not the same thing, even though it may both hurt the same way. It's a different type of thing. So I do have a practice where I see people with a variety of different issues, and I'm always looking for those that may have a mind-body issue, because sometimes you can have chest pain. Maybe a woman in her 30s have chest pain, so you're not as worried about a heart attack as you would be someone much older. But when you start investigating, it's not because they lifted something or they got punched in the chest or you have a lung issue. It's really because they're stressed out about something, and so you get talking about that. So there's a lot of people who don't realize they have a mind-body condition who do, but I also am fortunate to have been known in this field for a long time. So a lot of the people who I'm seeing for mind-body conditions are actually coming to me saying, I've read one of your books or one of Dr. Sarno's books, or I've met someone else in the field, and I'd like to really get a firm diagnosis from you. And that's a role that I play is the diagnostic, and then really outlining a treatment program, which might include referral to someone like yourself, referral to a local therapist or a pain therapist that I work with, a bunch of them, or a pain coach who has expertise in this area, and homework, journaling, reading, listening to podcasts like this is educational, watching one of the movies in the field. I mean, I kind of have a menu that I check off so they don't even have to take notes. And I say, try reading this and doing that and doing that. Come back in about 3 weeks and we'll see how things are going. And some people start improving very rapidly. Others take longer. It's just, everybody's different. I'm sure you find that as well.
Definitely. I'm even thinking, so what you said about the way you talk to people, especially in, a hospital, ER center, urgent care, around what they've just experienced, even when it is acute, can change the trajectory of their journey, of their healing, of their pain, right? I think that's really important and really huge, because yes, you can have an acute injury, right? But it doesn't need to lead into chronic pain if we can catch how it's understood and treated in the beginning.
I'm glad you're reiterating that, because I think that's a very important and strong point. And it's something that we should be teaching medical students and residents earlier in their career. And I think they get some training in communication, but I don't think it's adequate, because I'm constantly having to act as a deprogrammer, right? You've heard of deprogramming for cults. I act as a deprogrammer when someone has seen, let's say, an orthopedist or neurologist or something, and they're told, oh, this is a horrible back. In 5 years, you're going to need this and need that. And I say to them, wait a second. Let's look at that MRI. This is, this very often it's not any worse than anybody else I see at that age group, or minor changes. Hey, you've had an active life. You got a couple wrinkles in your face. You're entitled to have a couple of gray hairs in your spine, so to speak. So I change the whole dynamic by re-explaining that to them and taking down the anxiety, because there's a tremendous weight to sometimes what you hear from your physician or your practitioner. Could be a chiropractor, could be an acupuncturist, whoever you hear, there's an authority that you accept from that or believe from that, and it can be counterproductive. Many of your listeners may have heard of the term placebo, right? So a placebo could be a pill that's inert, or it could be something that's said, or just the healer themselves, and it leads to a healing response in the patient. But the opposite of a placebo, I don't know if your listeners have heard this term, nocebo. Have you heard that term, nocebo? Right. So a nocebo is the opposite. So I'm constantly seeing the effects of supposedly well-meaning physicians communicating to their patients in a way that leads them to get worse as a result of the nocebo that they say to them. And the nocebo might be, you've got a horrible spine, or you're going to need surgery in 5 years, or you're going to this or that. And again, I also say to patients, physicians who predict what's going to happen in 5 and 10 years are shifting from medicine to prophecy. And I didn't get any courses in prophecy during my medical school. So they should stick to medicine, which is what they're good at, diagnosing and treating. And some of them are good at the technical part, let's say, of surgery, but maybe they're not good at the diagnostic part of understanding why someone has pain. And this is evidenced by the fact, 2 of the last 5 new patients I've seen with this have told me they've seen at least 20 physicians before coming to see me. 20 physicians. And these are top, not Joe average physician, like the top people at different universities. I'm not even going to mention the universities they went to. 20 physicians and didn't get a diagnosis. And on their own, they found, and I mentioned to you before we started, how they found me. Makes an interesting story. And they eventually found me, and I'm taking a different approach to this. I'm asking different questions, and that can lead to a different outcome.
Yeah. Obviously, based on what you just said, and my experience too, by the time people get to me, it is after either years or 20 physicians or whatever it might be. And I hope that's starting to shift, right? The amount of growth that we're having in the mind body field. And also, it's still small comparatively, but I do think it's interesting how people are finding us. So tell us a little bit about that. How did they find you?
Yeah, I hope it is shifting as well. But I'll say one thing before I say that, which is desperation is unfortunately a great motivator for change. And so I'm not saying people should see 20 physicians, but I'm saying that if you see somebody, Grace, when, like I do, that they've seen 20 physicians or 20 practitioners, sometimes it's an alternative as well. They're actually often more ready to jump into the program when you finally explain it to them because they have tried everything else. They're desperate. But I don't want people to be desperate, but I'm just saying that's a reality. So here's the interesting story that I was going to share. The story I was saying was that of the last 5 patients I've seen, 2 of them told me that they came to me through AI, and I'll explain what that is. One of them was saying that he had seen 20 physicians, he wasn't getting an answer, and he has these conversations with Claude. So people know about Claude as one of the major AI products. It's made by Anthropic. And he's having this conversation with Claude. And he's saying, I've been to these doctors and this is what they've told me. And he's just kind of having a conversation and Claude's responding. And then he says, so I must have blank. I don't know what he told. He said, I must have blank. And Claude said to him, well, I might disagree with you on that. I think you probably have neuroplastic symptoms. Claude said this to him.
Yay!
And this is after 20 physicians with highly educated, highly credentialed, never mentioned. So he said, really, what? So he says to Claude, neuroplastic, what is that? And Claude says, well, and he explained it pretty coherently, what neuroplastic is. And he said, well, that's really interesting. That does seem like it might apply to me. Who are the physicians in my area that might treat that? And and there's a lot of psychotherapists doing this work. There's a smaller number of physicians. So he came up with a very short list of names. And I was at or near the top of that list. So he asked Claude to draft an email to my secretary, got my email address or something, and then sent it to my secretary. And that's how I ended up making an appointment. So I think that's an amazing story. That's one story. The other story of the second patient is this is someone who lives in another country. I'm not going to mention the country for privacy. And again, was searching out of desperation for a solution to his pain, which was a slightly different type of pain, more of a coccyx rectal type of chronic pain, but pelvic related stuff. And he asked another AI, I won't mention the name to keep it again very private. And he said, boy, is there anything else that could help me? I just am not getting help from, what have you tried? I've done injections, I've done this, I've done that. And the AI says to him, well, you might want to look into Dr. Sarno and Dr. Schechter's work on neuroplastic symptoms. Amazing. And he proceeds to, this is from a different country than the US, and he proceeds to do further research and find out about it and actually make a trip to the US to participate in this intensive program that I'm doing now through a related group where people can really be and live locally and see a bunch of therapists and pain coaches during the course of a few weeks. And he's doing great. But it's interesting, isn't it, in this modern world now in 2026, that these are 2 people who found me through AI, and AI was smarter than their doctors. So that's the amazing thing.
That is amazing. Because to be honest, there's a lot I see with where it can also perpetuate the fears that people have, and they go down the fear rabbit hole and OCD with health and continues on that.
Yeah, I agree with you. And sometimes it seems like AI reinforces your own prejudices or wants to kind of make you feel good by saying, oh yeah, you're so smart. It seems like it does that a lot. But for whatever reason, maybe it's the new models, maybe it's how he asked the question. maybe he had already exhausted his own options to be pleased and
Yeah.
coddled. And it finally just sort of say, wait a second, here's another way to look at this thing. So I think that's
That's
great.
amazing. I hope that I would assume it keeps happening, right? Because
Yeah,
it's
I mean,
already
I
happening.
don't want AI to treat my patients or treat any patients, but I like the
Right.
idea that it could give people ideas that they're not thinking of locally. Because, if you're in a small town somewhere 50 years ago, you might go to a local library and pull out books to look for things that you're
Mhm,
just not learning from your small town.
mhm.
And now we're all kind of in a small town and we have this language models that have a lot of information, kind of like an encyclopedia or a large library. And so if they can give us ideas that we're not hearing about in our local community, whatever that may be, whether it's Los Angeles or another country or Chicago or whatever, then it's great because it expands our mind a little bit without, forcing us to do anything. Yes. And there are definitely cautions on AI. We read stories about people with depression who ask about, how can I hurt myself? And it gives them suggestions on how to do it. We don't, that's bad stuff. But this
Yeah.
was two examples where people were actually told about the field that we are in, neuroplastic treatment, and just mentioned it as an alternative to consider, and then referred these people to places where they might get that type of attention or books that they might read to learn more about it. So I think that's fantastic.
Yeah, definitely. Especially because, if we're putting more information out there, right? You have books, you have website, there's a lot that the internet you can pull, AI can pull from the internet. That's why we're
Yeah.
trying to put as much information out there as possible. So hopefully they
Yeah.
can keep getting connected. So that's huge. Okay. I want to go back to the pain for a second, the knee pain specifically.
Yeah.
I have a few people in mind that I work with who it's interesting. There's what we talk about the chronic pain that has sometimes a hard time reprogramming because they've been in it for so long. But then these other symptoms pop up after they've been doing mind body work and actually they go away pretty quickly. And I have a feeling part of that is also because of what you just said. They already know what's happening, right? The way that you talk to or understand the pain in the first place changes the trajectory of it, right? If we have a new pain pop up and we know this work, in my shoulder, for example, it might go away because I'm not putting a label of this is wrong, this is bad, could get worse if you don't treat it in this way, right? But with the pains that have been there for a long time, I have noticed sometimes it's harder for those to subside, even when they're understanding this work. And so, can you speak to a little bit of when someone knows that they're in this work, they're not questioning it necessarily, but there's still something going on and they don't understand what to do with? Yeah.
Well, so it seems like someone who's accepting the diagnosis, who seems to be on board with doing the program, and yet they're not getting better from a long-standing symptom. So those are challenging, right? So
Mhm.
first of all, I tell people that, how long it's going to take to get better is very variable, and I can't predict it even after decades of doing this work. So I don't put pressure on them to sort of get better in a certain amount of time. And I do acknowledge that many people who've had symptoms for 10 or 15 or 20 years, it may take longer to change patterns than someone who's had it for 1 year or 2 years, although not always, but often. And so persistence is important, and trying different things along the line may be important because we can't keep doing the same thing over and over again. So, for example, if someone's using PRT as their form of therapy,
Uh-huh.
the term is pain reprocessing therapy, and someone's not getting better after 6 or 8 weeks of that, then you may have to bring other forms of therapy in,
Uh-huh.
whether it's EAET, emotional awareness and expressive therapy, or whether it's more psychoanalytic. I mean, there's lots of different therapies that people can use. That's why I tell people it's more important to have the right therapist with expertise in this field than it is to necessarily have the right type of therapy, because I think all of those therapies are just one piece of how a good practitioner can help somebody to get better. So I also explore doubts. It's normal for people to have doubts, and someone who's had this for a long time has a preconceived belief of what's going on. And I really want to chip away at that. So I want to really understand. So what do you think is going on, or what have you been told has been going on by other doctors? Do you still believe that? Do you believe it a little bit? What are you doubting? So the more we can find out about doubts, that's something that can be really important to understand so that we can slowly but surely chip away at it. And sometimes it takes a while to find that. The other thing for persistent symptoms in someone with longstanding symptoms is, it could go quite deep emotionally. When I was that 21-year-old medical student having knee pain, I wasn't that happy with the first year of school, and social life wasn't great, but it wasn't like I fortunately had to dig that deep into the emotional stuff to get better. Maybe I just had a simpler life at that point than someone does at 30 or at 40 or at 50. So for some people who have chronic longstanding symptoms, and by the definition of having it a long time, you've got to be probably at least 30, if not 40, maybe even 50 or more. You may have to go a little deeper. You may have to dig a little bit into childhood stuff. You may have to dig into things you thought you've dug into before, but you haven't completely. You may have to look at all of your relationships in a different way. You may have to look at your career in a different way. So it may just take a little bit more effort and challenge on the part of the practitioner and the part of the patient to get into all of those things and break the pattern. The other thing is when we talk about neural pathways and neural circuitry, it makes sense if you've had a pathway for 10 years or 20 years, it's going to be more entrenched in your system than it would be if it was 1 year. So it just may take a little bit longer to get away, to go away. And depending on the type of symptom, I focus a lot on a patient's capacity, sometimes even more than patient's pain. So what I mean by that is we obviously want the pain to go from 5 to 4 to 3 to 2 to 1 to 0. But let's say that person's pain is still 4 after a couple months. It used to be 5. But they used to only be able to walk 8 minutes, and now they can walk 25 minutes. Well, that's an improvement in capacity. Let's say they used to not be able to hit a tennis ball, and now they can hit a tennis ball at least against a wall. That's an increase in capacity. Let's say they're able to walk up 2 flights of stairs. So I focus a lot on getting people moving and doing things that they were not doing before, because then we might come into a situation 2 or 3 months later where I go, you're doing like 90% of what you actually want to do. And yes, you still have pain, but you've improved so much because you weren't doing any of these things before. So that proves that it's TMS. That proves that it's neuroplastic. So that hopefully reinforces and gets them encouraged to sort of be able to get the pain down now, because the pain is a vestigial remainder of the past.
Yeah. I'll echo one of those points. Well, all of them, but specifically, I have a similar experience when I was in grad school is when my pain was really bad in multiple different areas. And I went to a psychologist who helped me with it. And within about 6 months, about 90% of that pain went away. And we did some deeper therapy, but I wouldn't actually say it was a lot of deeper work. It was just changing the way I thought about it and understanding my body, right? And so I had a similar experience of, okay, I moved on. That is what it is. Cool. And then when I started to develop other types of neuroplastic symptoms like fatigue and histamines and other things like that, I did have to do more deeper work. And so I do think, are there associations with certain symptoms? I'm not sure. I think it's more about just the person's trajectory and what's going on in life and things like that. But I do think there's a time and a place for both, and it just depends on the person and life circumstances and how long they've been in it. There's a few things that I hear from people in pain, and specifically around whether it's like knee pain or back or shoulder, something like that that's in a joint, is the inflammation question, the tear, right, a tendon tear, something like that, and nerve damage. Can you speak to those? So we have that.
Let's start with inflammation. First one you mentioned. Inflammation in medicine is redness, swelling, pain, and warmth. And so sometimes people have one or more of those elements, but they don't really have sort of true medical inflammation. Like they might have swelling, but there's no warmth or redness. And so generally, neuroplastic symptoms don't cause dramatic inflammation compared to other conditions, but they can be associated with mild swelling and that type of thing. So, I'll assess anybody who feels they have inflammation. There's also something called microinflammation versus macroinflammation. And, I'll look at any kind of condition they have. I'm also willing to do blood tests, to rule out rheumatoid arthritis or these inflammatory diseases that are real and that sometimes need to be ruled out. And there's also research that even inflammatory conditions may respond to mind-body approaches, although perhaps not as dramatically or perhaps not without additional medication elements to it. So that's maybe a little bit about inflammation. Does that answer that piece of it?
It's more, I think I didn't say this. Yes. Usually I hear those three people, when people come to this work, they're like, hey, okay, I get it, but what about this? But what about inflammation? What if I have a tear? What if there's potential nerve damage, right? There's the question.
So tear, I examine them. I'm able to do that in my sports medicine experience and stuff. And then if I think there's a possibility of a tear, or if I think that they would benefit from getting imaging, then we get an MRI of the joint or the area that's irritated or painful. And then I review it with them. And, most people don't have what they're afraid of, or they have something incidental, like when you get to be a certain age, you may have a small meniscal tear, but it's not really the cause of the pain, or it could be in a different location. You have to read these reports or look at the images very carefully, because sometimes they have pain on the right side of the knee, and the left side is where there's a small incidental, meaning not the cause of the pain, tear. Nerve damage. Well, first of all, there's nerve irritation, nerve injury, and nerve damage. So nerve damage implies something kind of more permanent and more serious. Nerve irritation, if you hit your elbow, your kind of nerve gets irritated, your fingers are tingling for a while, and then it goes away. So a nerve injury can happen from a variety of reasons. Even muscle spasm in your neck or in your buttocks, your piriformis, can cause, in my experience, nerve irritation for a while, which could lead to symptoms in your arm or leg, but it doesn't mean it's damaged, and it doesn't mean it's permanent. It doesn't mean it won't go away with a neuroplastic approach. So I just try to individualize all those things. I mean, people come up with lists of fears. I mean, there's a person yesterday on a video call that just listed, 10 different things. What if I have this? What if I have cancer of this? What if that? And I started out by saying, let's just get an MRI of that. But then I realized it was way beyond one MRI. So I said, there's a book that I recently wrote the foreword to by a colleague of mine. It's called the Health Anxiety Workbook. I said, I think you should read it. He gives very practical suggestions on how to work with health anxiety. Sometimes health anxiety and neuroplastic overlaps a little bit. So he asked me to read it and write a foreword for him, or a quote or something. I forget what I wrote, but anyway, it's a good book, and it's in the realm of what I might suggest to somebody to get work on health anxiety.
Yeah, I see health anxiety a lot, and piecing out what's the anxiety versus actually what is real and true, right, can be so helpful to be assessed by someone like you. I think it's super, super important, because a lot of people come in after they've gone through all the doctors and years of searching. They have a lot of fear towards medical professionals and going to another one or getting assessed, because they probably will tell them that something is wrong, right? And so piecing out who can assess them from a neuroplastic lens, I think is so, so needed. So thank you for doing that.
So if you have a physician in your area, or who can do that neuroplastic lens, great. If not, you're stuck with sort of finding the least surgical doctor in your area. So, for example, a neurologist is less surgical than an orthopedist, and having them assess the area, and then ask them, so if you find something, is it serious or is it not serious? And sometimes they'll say, oh, you have this, but that's not serious. And then you go, okay, it's not serious. I'm just not going to worry about it. So you can try to get that type of help. But I wish there were thousands of doctors who were trained in neuroplastic and understood it, and that every medical student should learn about this and at least be aware of it. But it hasn't happened yet. It's been kind of a lifelong mission, and it hasn't gotten there yet. We're still working on it.
What does that look like to implement this with medical students?
Well, what it looks like is, we have the ATNS, the national organization, and we have a lot of different priorities in terms of how we advocate for this work. But if you have a medical school in your area and you're able to reach out to a dean of the medical school or to the Department of Pain, but that might be actually less likely to work, or sometimes the behavioral sciences department. Maybe you can get Grace to come in and give a lecture, or me to come in and give a talk or a virtual talk, and just, get it into the curriculum. I mean, that would be the goal. If you're a physician or a healthcare person listening to this, give that some thought. I've been thinking recently of reaching out to the osteopathic schools more. I've given a couple of talks. I think they might be more open to this than the medical schools sometimes are. So I'm making a note now about this one I've been thinking about contacting. But that's what it would look like. It would look like getting things into the curriculum that are like more important than what they're studying now, that aren't as important, because they always say, well, our curriculum is already full. Well, take something else out. Teach the doctors more about nutrition. They need to learn about that. They don't know enough about that. Teach them more about the relationship between mental health and physical health. They really need to understand that connection and pull something else out.
Throughout your journey as a doctor, especially starting to understand this as a medical student, did you have trouble, I guess, along the way telling other doctors about this, professionals? Like, how did you fit into that world of doctors, of medical
Well,
professionals?
either they were interested and didn't do anything about it, or they were resistant and thought I might be a little bit weird. I mean, I did go
Yeah.
into a field called family medicine, in part because I felt like it was the most biopsychosocial field.
Mhm.
But the behavioral sciences that I learned in my residency was not as advanced in some ways as the behavioral
Mm.
science as what I had learned from Dr. Sarno. So there
Yeah.
wasn't really anybody that could sort of add to what I had learned from Dr. Sarno. I learned a lot about every other part of medicine, but there wasn't anybody who could add to what I learned in the
Mm.
psychology, mental health area. So it took quite a while for me to sort of develop my own practice, my own office, affiliate with therapists that I gradually met who were interested in this and who had learned a little bit about it or wanted to learn more about it. And over time, that's what we have now. Many colleagues, like when we go to that conference and we see 300 people that
Uh,
we can talk the same language with. It's wonderful. But if you went to any medical conference in a general subject or even a pain conference, you'd find very fewer people that would
mhm.
speak the same language or believe that this works. And, it's starting to change. Some of our
Mhm.
colleagues have published some great research studies that have helped
Mhm.
to create more credibility for the field, although sometimes it feels like they're only credible for the narrow part of it rather than the broader part of what we're doing. But, it's been a slow process. People have to continue it because it's been slow to get it in there.
I find it similarly within therapist community. A lot of therapists I meet and talk to, and I tell them what they do, they
Yeah.
go, "Huh? What?" Like they don't know or understand, and so I'm working on that,
Yeah.
helping more therapists understand that, right?
Well,
And even just prep for
therapists
it.
will at least mouth the idea or mouth the words that
Yeah.
your
Yeah.
emotions affect your health, but they don't if they
Right.
haven't learned this, they don't know the power of this because the power is not
Mhm.
just helping people gain insight into their childhood and learn that they, had trauma as a child or that a
Mhm.
particular relationship with, is still affecting them emotionally. That's all important, and that's important work that they're doing. But they don't realize that that can actually take away pain. They don't realize that that can make a migraine headache problem that's been going on for 10 years go away. And so until
Exactly.
they learn that, until they believe that, I've always critiqued the field of pain psychology, for example, by saying that they learn in school that you can shave 10 or 20% off the top of pain, but you can't really eliminate pain. Whereas we've learned that in many cases, you can eliminate it down to zero. And in most cases, you can get a dramatic improvement in it, not 10 or 20%, but like 70 or 90%. And
Mhm.
so it just seems like, it's based on what you're trained. If you don't have that experience, some of the doctors who become neuroplastic doctors later on, it's interesting. I've talked to a few, and they've said, the reason I got interested in this is because a patient came to me and said, my pain went away. I read this book. And then they showed the book, and the doctor really doesn't want to read the book, but they go, oh, wow, that's pretty. And if they hear that a second time from somebody, then they'll read the book and say, how are these people getting better? Because they're reading a book. And so sometimes it's the patients driving the doctors to change
Mm.
or to adapt or to expand their style of treating things. And so I've also been working a little bit on getting some of this information into the high schools because if young people learn about this at the high school level, maybe in health education, then they'll become the future doctors and nurses and therapists. And they may also at least push their practitioners if they don't go into healthcare. Hey, what about this stuff about mind body? Could that apply to me here? And maybe that'll push people a little bit. So as a society, we need to just become more open to and aware of the power of this. And it takes a long time. There's a lot of entrenched interests. Surgery is a lot more lucrative than sitting and talking to people. Procedures tend to be more lucrative. Some doctors go into the field because they like science, but they don't like talking to people. And you got to really be able to talk to people to help them with this. Whether you're a physician, a therapist, whatever you are, you have to talk
Mhm.
and listen too. And some people don't like to talk and some people don't like to listen. So it's hard.
It's true. There's a lot of movement and also, yeah, it's a radical shift in understanding health. If you've understood it a certain way for so long and have been trained that way, it's a 180 of understanding what we're doing here. So it makes sense. Okay. Throughout your journey, because you have so much experience, is there anything else? And I know this is a broad question, and I'll bring it down. Is there anything else that feels really important for people to know when they're getting into this, right? They're recognizing maybe they read the book and they're kind of starting to do this work, but they're still feel like floundering a little bit and they're just kind of like, I don't really know what else?
So you're talking more about somebody who has shown interest and has read a little bit, but feels stuck. They feel like
And
they're
they're
not
still
making
questioning.
progress. They're quite still
They're
questioning. So doubts. So
Mhm.
doubts. It's important to identify exactly what you doubt. And our colleague Dan Ratner has done a good job with the different types of doubt. So you could doubt that neuroplastic conditions exist at all, in which case you have to read more about what neuroplastic conditions are and why they exist. You could doubt that you have a neuroplastic condition, in which case you may need to see a physician, even if it means traveling to someone. You may need to see a physician who can confirm that your condition is neuroplastic. And the third doubt that people often have is, well, I've got this thing, but I don't know if I can get over it. I don't know if I personally have the ability or the energy or whatever to get over it. And I would say that most people do have the ability to get over it. They may need some help, and that's why we're around, but they do have the ability. So those are the kind of doubts that I deal with when people are still kind of in it, but they're struggling a little bit. They're skeptical. They may need more frequent visits with a therapist, with a doctor, with whomever they're working with. They may need to stop doing some of the physical things they did before. I saw someone recently who seemed very interested in its work, but when I really questioned her, she was still seeing a chiropractor every 2 weeks, an acupuncture every 2 weeks, massage therapist every 2 weeks. I mean, she had like 5 different people she was seeing who were giving her physical treatments. And so I said, it's probably the time now for you. You'll save time, you'll save money. To me, that seems like a winner. Stop seeing those people and really focus just on this approach. But I think she just didn't have the confidence yet. I was trying to give her the confidence, help her with that. She didn't have the confidence yet to give up these things that gave her what she perceived to be at least temporary relief.
Huh.
So that's another thing that I will try to assess, is if people are maybe still too caught up in the old model that hasn't really fixed them, but they stick with it. They either like the practitioners or they think they're getting some temporary relief. I wanted to spend more time and resources with Grace and with people like you, and obviously see me, and really get a clear-headed approach going forward. Does that answer what you're asking on that case?
It answers it well. Thank you. Yeah,
Okay.
especially that last part. I find that often. And to be honest, yes, we can approach it and say, "Hey, it looks like you're doing a lot, right? You're seeing a lot of different people. First of all, that must be stressful. That's time and energy and money for temporary relief, right? And help them maybe understand that it could be time to pull back on that. And at the same time, I truly feel like, at least in my experience, everyone has a time that they are ready to let go of that and get into this. And a lot, to your point earlier, a lot of that does come from desperation of realizing, all right, I'm over this, nothing's working. Cool, fine. I'll try to eliminate, or I'll try fully going into mind body. And yeah, it just depends on the person.
I mean, it's important to be an ally and to advise. You can't push somebody out of what they are currently doing, and you can be an ally. You don't necessarily push, because people need to be, as you said, ready to take that step forward. And so you give your best recommendations, you explain why it's worked for other people, you explain why it worked for them. And then, they'll get to it when they're ready to do it. Sometimes it takes a little while. You have to be patient, but persistent.
Yeah. It can be scary to let go of that temporary relief. I've had that experience where I was like, oh, I know I'm really reliant. I'm so dependent on this. But I don't want to let it go.
I'll say to people, like, with regard to a practitioner, I'll say, if you tell them you're taking a break for a month or two, they're still going to be there. They're not like retiring in 2 months because you've decided to stop seeing them. So you can look at it as, I'm taking a break for the summer or the winter or Christmas or whatever they want to take a break for. You find something to take a break for. And then maybe once you're away from it, you'll have a different perspective.
Yeah. Yeah. Makes sense. Okay. Thank you so much for all of the wisdom that you've shared today. Is there anything else you'd like to share with our listeners?
Well, I mean, you probably put this in your show notes, but my website, mindbodymedicine.com, might provide some information and insights for people who want to learn more about this. And it talks about the various books I've written and that sort of thing as well. So that's not mentioned.
I'll link it all below. And actually, one more question for everyone. Do you assess people virtually, worldwide? Where do you see people?
Well, the laws for doctors are, you have to be in California when I do your assessment. So I have people who I can do virtually in other parts of California. It is a big state. Or if you're visiting California, or some people make a trip to see some friends or family, or go to San Diego or whatever and visit LA. So you have
Yeah.
to be, you have to be in California when I first visit with you, when I first make your assessment. And if you're out of the country, it's a little bit more flexible, strangely enough, but it's all about medical licensing and insurance and this sort of thing. But you could always inquire with the office, but I'm sort of limited to California for the initial visit.
Okay. And what about where could people find someone in their area? How could they find
Well, my
someone?
website lists about 20 different doctors in different parts of the
Okay,
US.
great.
And then the ATNS website, which is the nonprofit, which is currently symptomatic.me, has a directory of practitioners as well. It has probably more physicians than my website does, and it has therapists and other people as well. But obviously, you've got Grace, so you're good with that. But these are two good directories that are available.
Great. And I'll link those below too. Okay. Thank you again. And we will see you all next week.
Thanks for having me.